Today we are going to discuss about the basics and the clinical perspective of pneumonia. So it's going to be really going to the real understanding of what pneumonia means, how it starts, and how do we really interpret these different aspects of pneumonia. So as clinicians, I mean, all of you are doctors and you have done a lot of practice. You have finished 10 years of practice. Some are on the verge of practice. Some are dreaming of practice. So at some point of time, each one of you will be holding an X-ray in your hand and explaining what is happening to that particular person who is sitting in front of you. And this is where, instead of that person with the specs, I suppose each of us should imagine yourself in that position. So try to understand, try to first imbibe the thought that you are seeing an X-ray and you are trying to interpret and tell a person what you could see from the X-ray. Now, X-rays are something like an image, a mirror image of what is happening inside the lungs. So I'm showing you a couple of X-rays at the beginning so that you start actually feeling yourself that you are seeing a patient, you are understanding what is happening to that patient. So this is a typical X-ray of a patch. I'm using a very layman term, patch. And where is the patch? If you try to distribute the lung, what I mean by the lungs is the area of the lungs on either side of the heart, then we need to distribute into the upper zone, the mid zone, and the lower zone. So please, each and every aspect of what I'm trying to tell you will be somewhere or the some time or the other useful to you when you interpret X-rays, not necessarily always of pneumonia, but any lung disease. Now, another trick, I can say a trick to interpreting X-rays is always compare the right with the left. So you compare the right upper zone, the left upper zone, the right mid zone, the left mid zone, the right lower zone, and the left lower zone. Okay. So in this particular X-ray, if each one of you are able to appreciate, then there is a patch, what we call as a opacity. Opacity means it's more white on the right lower zone as compared to the left lower zone. So there is a patch, which means it's a opacity. What do we mean by opacity? Opacity implies that the air in that part of the lung is lesser, and that part of the lung which had air is now actually replaced by tissues, by solids. And solid give rise to a opaque picture or an opaque image on the X-ray. So X-rays are going to be just a guidance about where is the opacity. We do not know whether it's a mass, we do not know whether it is TB, whether it is bacteria, whether it is fungus, we do not know that. So this is going to be very simple understanding of what we mean when we say that we tell a patient, see, I feel your X-ray is suggestive of a pneumonia, or you read a report on the radiologist comment saying X-ray is suggestive of a right lower zone pneumonia. So a haziness or opacity, which is not shifting the structures near to that opacity, is usually a consolidation or a pneumonia. Okay, so you see a opacity, but the structures which are close to the opacity are not getting pulled, neither getting pushed, then that opacity is most likely going to be a pneumonia or a consolidation. Now let's see one more X-ray. Now I'm going to pause here for maybe 15 seconds for all of you to see this X-ray. And if you have seen the X-ray, then compare first of all the upper zones on either side, the mid zones on either side, and the lower zones on either side. If you have done that, then by now what you should have seen is that there is a opacity in the right upper zone and the mid zone as compared to the left side of the lung. If you have done that, then I will say you are at least 30% of your job of understanding pneumonia is done. Okay, so there is a opacity in the right mid zone and the lower zone as compared to the left side. The trachea is in the center. You can see a black or a blackish line right in the center. That's the trachea. So it is not pulled, neither it is pushed. The heart is in place, the diaphragms are in place. So that is what we can say. It's a inhomogeneous opacity in the right upper zone or the mid zone, we can say, which is not shifting the mediastinum. So if I know the history, then I can call it a consolidation. X-rays are a part of the patient's story. You have not read the entire story unless you have known the history of the patient, unless you know the symptoms of the patient. So this is one of the X-rays. Now let's see this X-ray. Again, I pause for maybe 5 to 10 seconds. Try to understand. Try to first of all imagine that you are holding this X-ray and you are trying to interpret this X-ray. The patient is waiting to hear from you. The patient is anxious because by now he has read the report and the report says possibility of TB or query tuberculosis etiology. So X-ray, now this X-ray is showing, again, let's compare. We don't have to start thinking of TB and malignancy and so on and so forth. So what we can see is there is a opacity in the right upper zone, and compared to the left upper zone, there is an opacity. Also, there is an opacity in the left mid zone and the lower zone as compared to the right lower zone. So there are two opacities in the right upper zone and the left lower zone. All right. So if you are getting this, then we proceed. Dr. Rucha, is this going okay? Am I audible?
Yeah, sir, it's going perfect.
So if you want to stop me anytime, if there is a query from anyone, please tell me to stop. I will stop and I will solve that doubt. Okay?
Yeah,
Okay?
yeah.
Sure.
If you have any queries, just put it in comment box. I'll take it up.
Yeah. So moving on. Now let's go directly to what actually happens when we talk of a pneumonia. See, there are very many things a patient will come to you with. A patient will say कि मुझे खांसी बहुत आ रही है, कफ बहुत निकलता है. Patient says I feel exhausted, I feel tired. Patient says मुझे बुखार है, मुझे भूख नहीं लगती है, मुझे सांस फूल रही है. Now all these symptoms arise because of this particular anatomical diagram in front of you. Now we are going to try to assimilate anatomy, physiology, pathology, microbiology, biochemistry, symptomatology, radiology, and come to a clinical diagnosis. Let's see how much time it takes. Maybe if we finish it an hour or so, or maybe a little extra, or if people are sleepy and Dr. Rucha tells me that's enough, then we will move on to some other day sometime. But till the time you people are not bored, we will try to continue this. So anatomically, we can see there's a trachea, there is a bifurcation of the bronchus, then there are the lobar bronchi, then the segmental bronchi, the bronchioles, and the alveoli. Now, our focus today is purely going to be the bronchioles and the alveoli. That is going to be our focus. Why our focus is going to be that? Because when I say today that we are talking of pneumonia, the disease is in the alveoli, in the smaller airways, and that particular anatomical aspect of the respiratory tract is termed as parenchyma. It is termed as parenchyma, lung parenchyma. So it is the alveolar duct, alveolar sacs, and you can see the saccular arrangement. Now, to be more precise, you should know this diagram. This diagram is actually given in physiology books, where you can see the RB is the respiratory bronchioles, and they keep on dividing the RB2, RB3, then the alveolar ducts, and then the alveolar sac. This is the parenchyma. And whenever you have seen a patient whose X-ray shows a haziness or a patch or opacity, the ones which we saw, and you have told the patient, आपको pneumonia की शिकायत है, आपको pneumonia है, your X-ray shows a pneumonia. You are actually trying to tell the patient, dear friend, your respiratory bronchioles, your alveolar ducts, and your alveoli are undergoing some pathological change, some anatomical change. All right. So try to put each and everything into perspective. X-ray shows opacity. It's an inhomogeneous opacity. No shift of the mediastinum. You need to compare it with either side. And what is happening actually internally, the parenchyma. What is the parenchyma? The respiratory bronchioles, the alveolar ducts, the alveolar sac of that person are getting affected. Now let's be a little magnified image of the same position, same area, where we can see that there is an airway, that is the air goes into the alveolus, that is called as ventilation. Okay, the fact that air passes through the lumen of the trachea, the bronchus, the bronchi, and then they reach the alveoli is the ventilation. The oxygen, it crosses across the alveolar basement membrane into the blood vessels, into the pulmonary circulation. That is called as diffusion. And the oxygenated RBCs flowing through the pulmonary vessels is the perfusion. So there are three things which are happening. So try to imagine these things happening as we move on with today's topic, which is pneumonia. I'm emphasizing that pneumonia means alveoli. You can see that the normal alveoli or sac and the filled up alveoli with secretions. That is the simplest way you can understand what happens in a patient of pneumonia. Many times I have heard students say, sir, on auscultation there are vesicular breath sounds. And when I ask them, why do you call them vesicular? There is a silence. So the explanation is very simple, because alveoli are sacs and sacs are vesicles. So any air which is entering the alveoli causes vibration of the sacs, and that sound is called as vesicular because they are the vesicles. So the same change happens in this particular alveoli, as you can see from the diagram, that there are secretions which get collected in that particular area of the bronchi or the respiratory bronchioles, the alveolar ducts and the parenchyma. Okay, so this is what is called a pneumonia. Now, if you read up the books, any book you take, Hutchison, Gray's, anything, what is a pneumonia? It's an acute inflammation of the lung parenchyma. All right. So let's dissect each word, acute. So the history has to be usually from 8 to 10 days. It may go from 2 to 3 weeks also. So acute history. Inflammation. What is inflammation? It's the change which happens in that particular anatomical location because of a pathology. So there is something abnormal which happens and there is inflammation. And we very well know the changes which happen in inflammation. The most common and the most important change which happens is lot of cytokines, lot of mediators. They start getting collected in the area of inflammation and they are causing more swelling. Okay, so gradually we are now understanding what is happening in this patient to cause solidification of the lung. Remember in the X-ray, what did we say? That X-ray becomes opaque. That part of the lung becomes opaque, means the lung is replaced by secretions and solid tissue. So let's see what exactly happens. Again, to make it very basic, a normal alveoli and the alveoli, the parenchyma filled up with secretions. When I say secretions, it actually implies mucus and pus. And the alveoli become congested. Okay, it becomes congested. Too much of crowding in the alveoli which was empty. So it's like a train compartment which was empty, and suddenly at 8:30 a.m. the office time starts and the entire compartment becomes congested with people. Similarly, this alveoli gets congested with mucus, with pus, with neutrophils, with bacteria, with macrophages. So there is a congestion happening in this alveoli, and that stage of inflammation is called as stage of congestion. It's absolutely very logical why it's called a stage of congestion. Now, if this is the stage of congestion, the one which you are seeing right now, then what will this person tell you? So he is going to tell you, you are going to ask him, आपको तकलीफ क्या होती है? He sits in front of you. Let's say you have started your clinic today and you get the first patient in front of you. Okay, he comes and sits. You are happy because the first patient has come to your clinic. Obviously, the patient is not very happy because he is a patient and he sits in front of you. Ask him, क्या तकलीफ होती है? What do you have? What problem do you have? And the patient says, this particular patient, I am talking you of the patient in the slide which this patient has. He says, मुझे खांसी हो रही है, मुझे कफ हो रहा है, मुझे बुखार आ रहा है. Okay, so three things he has told you: cough, expectoration, fever. Remember, fever is the most important sign of inflammation. The fact that he's saying secretions, balgam aa raha hai, expectoration, means the mucus glands are secreting excessive mucus. Now, if I hear this, I am going to surely start this patient on a mucolytic because he's talking of mucus and he's talking of mucus which is causing him irritation and discomfort. So this person at the stage of congestion tells you, मुझे खांसी हो रही है, मुझे बुखार आ रहा है, मुझे चेस्ट में टाइटनेस लग रहा है, and you ask him, आपको सांस फूलती है, दम लग रहा है? He says नहीं, सांस नहीं फूलती है, खांसी है, कफ है. And you tell him, लेकिन सीढ़ी चढ़ेंगे तो दम लगता है. Then he realizes, हाँ, सीढ़ी चढ़ेंगे तो सांस फूलती है, जब मैं जल्दी जल्दी चलता हूं तो सांस फूलने लगता है. Which means that his oxygen demand and supply are not going synchronized. Okay, so the oxygen requirement is more when he exerts, what we call as the work of breathing, but the supply of oxygen is not what is required, is not as much as is required. So there is a exertional breathlessness, there is a cough with expectoration, and there is fever. This is stage of congestion. X-ray will show a patch, inhomogeneous, no shift of the mediastinum. History will be 5-6 दिन से बुखार आ रहा है, खांसी आ रहा है, कफ है, बलगम है. And the alveoli actually will be something like this as you are seeing on the X-ray. So we talk of the first. Now this is pure theory, and sometimes I really don't like theory, but we need to complete the understanding based on the stages of what we call as consolidation. So stage of congestion. So stage of congestion is the cells. Now you imagine that there is a bacilli which has come into the alveoli, and this alveoli which was empty contains the bacilli, contains mucus plugs, contains neutrophils because they are the cells of acute defense. So neutrophils, these neutrophils are releasing cytokines. So more inflammation is happening. And this alveoli which was empty is getting congested. Patient says khasi, bukhar and exertional breathlessness. What happens next? Now two things happen at every juncture. First point is if the patient's immunity is improper. Okay, see now the point comes as the host immunity. That's why when you're talking of pneumonia, you should always do a blood sugar of the patient. Even if he says मुझे तो diabetes नहीं है, even if he says मेरा diabetes का कभी problem ही नहीं था, still when you are saying blood test, sending blood test, please do a blood sugar, whatever the age of the patient. Because immunity is very important, and today diabetes is the most important factor which causes immunity to come down. So we are trying to put investigation also into the picture. We are trying to put the symptomatology also into the picture and putting anatomy and pathology also into the picture. So patient says khasi hai, cough hai, bukhar hai. Now you're going to also tell him to do a sugar when you're planning the investigation. He also says exertional breathlessness. Now mark my words here. You ask the patient, cough kaun se rang ka hai? And he says it is yellowish or greenish. So it means pus cells. More the neutrophils, more yellow the sputum, more yellow the expectorate. So if he says ekdam pila pila nikalta hai, that means there is severe inflammation, more number of neutrophils. All right. So mucoid, less neutrophils, purulent, more neutrophils. 6 days have passed. He comes to you in the next stage. What happens at that point of time? The lungs become so sensitized with the inflammation and the cytokines that the vessels in the periphery of the alveoli, they become more permeable, they become dilated. So there is vasodilatation and increased permeability. So the WBC start getting entry into the alveolar area of disease. Along with the WBCs, obviously some amount of RBCs also land up over there. So now this patient says, मुझे खांसी आ रही थी साहब 5-6 दिन से, कफ भी था, हरा हरा था, बुखार भी था, चलेंगे तो सांस भी फूल रही थी, लेकिन क्या हुआ है सर कि सुबह को मैं जब ऑफिस जा रहा था तो खांसी जोर से आई और ब्लड आ गया, रेडिश कलर आया था, मुझे बहुत डर लगा, इसलिए मैं शाम को आपके पास आ गया. Now he is saying he is getting hemoptysis. Now this means the stage of inflammation has reached red hepatization. Okay, that is red hepatization where RBCs also come into picture. Now, at this point, obviously the patient comes to a doctor because blood in the sputum is something which is like a shock wave runs through the patient. Cough for 5 days, patient doesn't come, but one 5 ml spit and blood, patient will run to the doctor. So he comes to the doctor, doctor does an X-ray. Each one of you, imagine you are seeing this patient. Imagine you are advising this patient to do a X-ray, and X-ray shows a patch. There is a haziness. You are going to investigate further, and that's what we will decide, because you need to know what happens next. That's very, very, very important. Okay. So now we have, I will not go into the next stage because it is all about gray hepatization and resolution. But I will come back sometime to this gray hepatization. First, let's stick around and understand what happens in red hepatization. So this is a little bit of a smaller slide because obviously histopathology, and we are talking of histology, not one of the most loved subjects amongst the clinicians, because it's usually studied only for the exam sake, and the pathologist is the one who tells us what's happening, and we have read of histology more so because we want to finish the journals with the eosinophil staining and the reddish staining and all those things. But please remember, you will have to go through this particular diagram which talks about the stage of congestion, stage of red hepatization. This is very, very, very important, because if I just start talking about streptococcus pneumonia, Klebsiella pneumonia, and mycoplasma pneumonia, trust me, you will actually not remember what I spoke, because all this has been told to you. Sometimes you have read it also. But we need to really understand what happens in these lungs to know when we treat a patient with augmentin or piperacillin or ceftriaxone or so on and so forth. So stage of congestion, as you can see, there is only and only inflammatory cells and neutrophils. Stage of red hepatization, RBCs come into picture, and that's why the lung appears red in color. And since it is getting filled up with tissue, there is solidification, and this solid content or this solid texture is compared to the texture of the liver, and so it's called as red hepatization. Now I assume everyone has understood till here, stage of congestion to stage of red hepatization. Dr. Aman Raja is saying, I also don't like histology. So I am your, I think our interests match in that respect, but we need to learn this part of histology because I am trying to explain to you as much as possible. So the red hepatization stage is where you are going to intervene, you are going to treat. Now let's come to a very simple parameter called as C-reactive protein. At this point only I am telling you, because we are talking of inflammation, and C-reactive protein is a protein. Naturally it's C-reactive and protein. So it is synthesized in the liver, and any inflammation anywhere in the body, it increases. This increases. Okay, C-reactive protein increases. So at this point, when the patient has come to you with cough, fever, and hypoxia, or maybe exertional breathlessness, you tell him blood tests. You are going to tell him a CBC. I'm going to come to leukocytosis and leukopenia later. But one of the markers which is doing the rounds now is about CRP. So CRP is going to be high. Okay, it is obviously going to be high. So you should remember that in blood test CBC we are going to do a C-reactive protein. Now one more marker comes into picture, which is called as the procalcitonin. This is all part of stage of congestion and red hepatization. That's why I have put it here. That is procalcitonin. Now what is procalcitonin? It is a marker. It is a biomarker. Means whenever there is a bacterial inflammation, just mark my words, whenever there is a bacterial inflammation, it upregulates the synthesis of procalcitonin. It upregulates, and procalcitonin is pushed in the blood. All right. So there are two inflammatory markers. One was CRP. Second is procalcitonin. What is the difference? CRP increases in any inflammation. Any place there is inflammation, CRP will be high. You talk of myocarditis, rheumatoid arthritis, pneumonia, any place. What is procalcitonin? It is a marker which actually tells you more clearly about a bacterial inflammation. So now it's left to you which marker you want to do. I'm not going to tell you which one you should do. I'm leaving at that point. So these are the two important markers. You decide which one to do, and then according to that, you will have to tell the patient. Suppose you have done a good marker, you have found that the treatment is perfect. You treated the patient, okay? You treated the patient, and patient starts getting better. Now comes the problem at this point. The patient is treated very well by you. You talk of Dr. Eman, you talk of Dr. Raja, you talk of any person who has been in our list of attendees today, and each of you have treated the patient correctly. Now, two ways happen. One is a stage of fibrosis, means the macrophages, they induce fibroblasts, and fibroblasts leave their fibrous tissue, which is gray in color, and it is solid, so it is called as stage of gray hepatization. That is the stage of fibrosis. What is the stage of resolution? Stage of resolution is that there is no fibrous tissue left at all. The treatment was given, but the disease completely cleared without leaving any scarring. That is the stage of resolution. Now, why this is so important is because you will see many patients of TB, many patients of pneumonia who come to you even after 6 years saying, Sir, mere X-ray ka wo patch hai na, wo ja nahi rahe. It is not going at all. Now that is actually the stage of fibrosis or scarring. Whereas you will see other TB patients whose X-ray is normal, and you ask, did you have TB in the past? And that person says, yeah, 5 years back I took treatment for TB and now I'm fine, but his X-ray is normal. So there is a difference in what happens beyond the stage of red hepatization. Few go in the stage of fibrosis, few go in the stage of resolution. Remember, there is no disease left. Fibrosis is scarring and it is going to be permanent. The problem is it's going to be permanent on the X-ray. The patch is not going to go away. Whereas in resolution, the X-ray becomes normal. Now, why this is important? Let's go back to the patient. I mean, all these things which we learn, at this point of time, after seeing patients and patients and patients, now I realize when my pathology teacher used to tell me, okay, read the Robbins properly, read the Chota Robbins, read the Bada Robbins, you should mug it up, you should remember it. My physiology teacher used to tell, draw diagrams of histology, do this, do that. It is all actually coming back when we see patients, when we see X-rays and the X-rays have not cleared up. So that is the stage of fibrosis or gray hepatization. Okay. Now this fibrosis or gray hepatization is never going to go. Now the question which I suppose each one of you should have in your mind, or if not you, the patient definitely has in mind, कि डॉक्टर साहब अभी ट्रीटमेंट तो हो गया पर ये दाग क्यों नहीं जा रहा है? Now see, the answer is in the particular history taking. Okay, what is history taking? Patient had a disease, say on Monday, okay, on Monday, and he took the treatment or he started the treatment from say Friday. In 5 days, he started the treatment. So the duration of onset of disease and onset of treatment was not much. But you imagine a patient who is got the disease today, say 23rd of July, and he actually neglects himself, takes wrong treatment, doesn't go take the medicines properly, and starts the correct treatment after almost 4 weeks or 3 weeks. So what is happening? The onset of disease and the onset of the correct treatment is much wider. More wider this time, more chances that the person will develop fibrosis or gray hepatization. All right. So it's not in the doctor's hand. No doctor can decide what will happen. But why this is important is that if this patient which we were talking about, खांसी आ रही है, बलगम आ रहा है, बुखार आ रहा है, he comes to you, you treat the pneumonia. Please tell him that X-ray may not become completely normal. X-ray may leave a scar. If you do not tell him, the patient may still feel कि रिपोर्ट में तो सर अभी भी लिखा है कि एक्सरे ठीक नहीं है, अभी आपने तो बोला था ट्रीटमेंट हो गया, you have told me treatment is completed. So please, this is very, very important that you should be understanding while telling the patient, counseling the patient. Okay. So stage of gray hepatization, stage of resolution. Now this is the gross anatomy. So you remember your first MBBS days or the first year medical school days where we were pushed into the anatomy hall. It was formalin stinking and you were dissecting and you could see the gross appearance of the lung. So this is how it looked like. It was red hepatization. I'm sure no one really paid attention that time because everyone was so much anxious, apprehensive, excited to be in an anatomy dissection room. But this is how the red lung looks like. It is red in color and solid as well. Yeah, so I can
Yeah,
see
so I
one
can see
doctor
one
about
doctor
Dr.
about
Rajat
Rajat
Rane talking
Rane
about
talking about
ferritin.
ferritin.
Yes. So that's definitely a very important marker. Again, I can say where ferritin talks about inflammation and it can tell you the prognosis. Okay, so very good question, very good point to be noted about ferritin. So ferritin is one more blood test which we can actually do to know about sepsis, severity and prognosis. So CRP, procalcitonin and ferritin. Now going through the basic again, we come to this patient. Now remember there were three symptoms which he had. One was fever, second was cough with expectoration, and third was breathlessness on exertion. Okay, exertional breathlessness. So we are going to tackle the exertional breathlessness aspect now. Fever is because of pyrogens. So cytokines, mediators, they release pyrogens. Pyrogens is that particular molecule which causes genesis of pyrexia. So pyrogen. So the fever comes into picture. Inflammatory, exudate, neutrophils, macrophages, debris, mucus, everything is the expectoration. So cough with expectoration, fever, and we come to hypoxia. Now you need to understand this particular diagram or maybe a diagram after that, but try to just remember that when we breathe in, you, me, and all of us who are sitting in our comfort and we are breathing in oxygen and we are exhaling, the amount of air which all of us are breathing right now is 21% of oxygen. Okay, so we are breathing in oxygen which is 21%, which contains air which contains 21% of oxygen. That's why it's called as FiO2, fraction of oxygen in the inspired air. Okay, fraction of oxygen in the inspired air. So we breathe in that, it goes into the alveoli, it disperses across the basement membrane into the capillaries, and we are maintaining our saturation. That's the perfect balance. So there's ventilation, diffusion is happening in the interstitium, that is a space outside the alveoli, and perfusion is happening in the blood vessels. So there is a matching between the ventilation and the perfusion. So V is equal to perfusion, that is ventilation is equal to perfusion. Now perfusion is denoted by a constant Q. So ventilation equal to perfusion means no hypoxia. All right. Ventilation equal to perfusion means no hypoxia. What happens in consolidation? What happens in pneumonia is that this alveoli contains a lot of debris. So the oxygen molecule is reaching into the alveoli, but there is so much of secretions in the alveoli that it is unable to reach into the capillaries. This causes a mismatch between the ventilation and the perfusion. Means ventilation slows down, perfusion is happening at its normal pace. The pace is going on, the RBCs are moving, but the amount of oxygen molecule reaching into the RBCs is lesser. All right. So there is a mismatch between ventilation and perfusion, and this leads to hypoxia. So what is the cause of breathlessness in pneumonia? It is hypoxia. What is the mechanism of hypoxia? VQ mismatch. So there is VQ mismatch, there is hypoxia, the oxygen saturation, the amount of hemoglobin which is saturated with oxygen reduces, and the heart pumps the lesser oxygenated oxygen. It goes through the aorta and it reaches the carotids, and the carotid body, that is the carotid chemoreceptor, senses that there is less oxygen in the blood, and it sends signals to the apneustic center and the pneumotaxic center, and that sends efferent signals to the intercostal muscles and the diaphragm, and the person starts breathing faster, which we call as tachypnea, and he becomes aware that he has actually exerting to breathe. He has to do some effort to breathe, which is called as subjective awareness of one's own breathing. This definition is of dyspnea. So dyspnea is subjective awareness of one's own breathing. That happens in a patient of pneumonia, which is exertional. Exertional because the work of breathing is more, but the oxygen supply is not adequate. And all this is happening because there is VQ mismatch. And VQ mismatch is happening because the parenchyma is getting inflamed. Okay, so we are trying to combine everything in this patient. We understood why there was cough with expectoration. We understood the color of the sputum also. We understood about the fever also, and we understood about the hypoxia also. So as the patient becomes more breathless, what is happening? The ventilation is becoming lesser and lesser, and the perfusion is remaining normal. So the VQ mismatch is worsening. So if you are treating a patient, let's assume that you all are treating a patient. He's a 60-year-old man who says, "Sir, I checked my saturation today and it was around 91. My fever is still continuing. I'm still getting cough, and I'm taking your treatment. I'll come back after 4 days." He comes back after 4 days. You check the saturation in front of you, it has become 85. So from 91, it has dropped to 85. The same patient sitting in front of you after 4 days of treatment. Why it is happening? It is happening because the VQ mismatch is worsening, means the ventilation is reducing and the perfusion is remaining normal. Okay, so the saturation is decreasing and the VQ mismatch is worsening. Now let's see what is this diagram. Yeah, so you can try to understand from this diagram something more. We are going towards evolution of a pneumonia, I can say. Try to focus on this diagram. You can see right in the center normal VQ. Okay, that is normal ventilation and perfusion, normal VQ. So the person maintains his blood oxygen levels. Now you see the left side, there's a completely blackened alveoli, where in this case the alveoli is so much filled up with secretions and pus and bacteria and macrophages that it's almost completely there is no space in the alveoli to actually the oxygen to go inside. So there is no ventilation but normal perfusion. That is the extreme of a VQ mismatch. No ventilation, normal perfusion. That is called a shunt. Okay, that is called a shunt. Now I will try to put it in the form of a patient because this becomes too bookish or too theoretical. Now this same person who had saturation had dropped to 85, say he was somewhere between the normal VQ mismatch and the shunt, that is the low VQ. You can see that was a patient of consolidation where the ventilation was less and the perfusion was normal. Now he comes back to you after 10 days of treatment, and by the time he comes back to you, his saturation is 78, and you tell him, please get admitted. You need to get admitted. You tell the relatives, rush him to the ICU. We can't have a patient with a saturation of 78. And you rush him to the hospital. He's in the ICU. You give him oxygen, but the saturation only comes to 85. It doesn't go to 98. That is because there is a shunt which is happening now. Means the alveoli are so flooded with secretions, with pus, with macrophages that even if you are giving oxygen, the saturation is not improving. This scenario is called ARDS, acute respiratory distress syndrome, ARDS. Okay, so it's an extreme of the VQ mismatch and it is called a shunt. And the characteristic is you give oxygen but the saturation doesn't improve. And why I'm putting it in this slide, though we are talking of pneumonia, because ARDS is the most dreaded complication of pneumonia. Okay, this is a very, very important aspect you should remember. So a patient comes to you. Let's go back to the patient again. He comes to you with an X-ray. I think we are a little wiser now, wiser by last 40 minutes of my talk. So he comes to you now. He says, I'm getting cough, I'm getting fever, I'm getting some amount of breathlessness, but only when I walk. It's been there since a week. You say, get an X-ray done. You do an X-ray. It shows a haziness or a patch which is inhomogeneous. And you now understand, खांसी है, cough है, बुखार है, patch है, means this is a consolidation. You ask him, do you smoke? Because the way we thought of diabetes, we should also know smokers have a poor immune system and can progress to more disease. So do you smoke? Then we ask, do you have alcohol? Because alcohol is another factor which causes a lot of aspiration. It also reduces the immunity. So you need to ask of alcohol. Then you ask him, do you have any other comorbidities like a kidney disease? Because that again causes a problem, because we are going to use antibiotics and we need to be having kidney creatinine good, because many antibiotics are passing through the kidneys. Then we ask him, do you have any liver problem? So we are going to evaluate, in short, a CBC, possibly a CRP and a procalcitonin and ferritin. I am not going into the debate of why not CRP only, why not only ferritin, why not procalcitonin. I think we can reserve one of the talks just on biomarkers of inflammation. But CBC is a must. We are going to do sugars, that is utmost important. You are going to do a creatinine and a BUN. Remember, it is very, very, very medicine, very, very, very important. Okay, creatinine and BUN. If you find that the creatinine is more than 1.5 or the BUN is more than 30, it means you need to be very careful with this patient. Okay, so CBC ho gaya, sugars, BUN, creatinine. Very important, 4 parameters. Now, one more aspect I am going to add to it, which is going to decide his prognosis. Because these diseases which cause hypoxia and cause so much of inflammation, they have an impact on our metabolism. Even our electrolytes are very important when you are treating a patient of pneumonia. If the sodium is less than 128, or I would say less than 129, it is a very, very important parameter as a prognostic sign, because this patient can develop fatigue, he may develop drowsiness, he may develop altered sensorium. So I'm trying to explain to you all together, because we cannot have everything as a separate talk. But since you're treating a patient of pneumonia, now understanding pathology, you're understanding hypoxia, you need to know that when you are advising blood test, there has to be a reason. It's not going to be a fever panel. Just do a fever panel and do everything. I don't know what it is for. It's not that. You need to know each of those parameters why you are advising. Hemoglobin, leukocytosis and leukopenia, both are important parameters to decide about the severity. Counts more than 12,000, counts less than 3,000 are important prognostic markers. Okay, leukopenia is not good, leukocytosis is not good. So both are important. We are going to talk about the BUN creatinine. We are going to do a liver function test. We are going to do, more importantly, electrolytes. Okay, so these are prognostic markers. Liver enzymes may not be done at the first shot unless there is a patient with a liver disease. So just proceeding, because I think we are 15 minutes short of 10 p.m. I hope people who have had dinner are not falling asleep, because this is a very important topic, and I am sure everyone will come across pneumonia patients very often. So there is this particular shunt, normal and a dead space. I'm not today talking of dead space because that's a completely different entity, but try to remember that VQ mismatch is the reason behind hypoxia in pneumonia, and the severe pneumonias actually have ARDS, or they go into ARDS. Now, this is breaking into absolutely the microbiological aspect, or we can say the physiological aspect about pneumonia. In each and smallest, though the slides and the headings are very small, I will explain to you in simple words, is that it only implies that neutrophils come into picture. Neutrophils, macrophages, fibroblasts, lymphocytes, and fibrin. And all these release extensive number of markers, especially the neutrophils, which are I think IL-6 is something which is very common now because of COVID. I think, forget the doctors, even the patients are knowing about IL-6, though half-hearted, but they still know it. When we go for rounds, I suppose each of you who have worked with COVID patients, they themselves ask, sir, mera IL-6 आज कितना है और मेरा CRP कितना है. So interleukins are one of the important factors of inflammation or markers. So we should be, all these things come into picture. So the things which we perhaps ignored in our first MBBS and second MBBS are coming back to haunt you. when you become a medical doctor. Okay, they will haunt you in terms of the histology and the pathology. And in the terms of the microbiology, we have not yet touched upon that part, the gram positive and the gram negative and the other things. But this is what a gray hepatization looks like. Okay, gray hepatization. So the area which was red becomes gray, it is solidified and it looks grayish in color. Now, having explained to you about symptoms, about the pathology, anatomy, we will come a little more towards the microbiology. Okay, microbiology. It is very important because we are going to tell the patient to do a sputum test. We are going to choose our antibiotics. Everything depends on the microbiology. So before you start reading this slide, let me tell you one thing, that there are two basic types of pneumonia. Simple way to understand is a community acquired pneumonia and a hospital acquired pneumonia. We are sticking only to a pneumonia as a broad base, because if we understand this, we can sometime go into detail of hospital acquired and many things more. But let's first understand that the commonest reasons why a patient develops pneumonia in the community is because of streptococcus pneumoniae. Then there is a organism called as Moraxella catarrhalis. Then there is an organism called as Haemophilus influenzae. And there are atypical bacteria like Chlamydia, Legionella, Mycoplasma. So remember, again we put it one together. A patient comes to you with a community acquired pneumonia. Let's go back to the same patient. He says, मुझे खांसी है, एक हफ्ते से बुखार है, दम लग रहा है, कफ निकल रहा है, पीला पीला कफ है, चलेंगे तो सांस फूलता है. He is a non-smoker. He's come to you in the community. Which are the organisms? Either Streptococcus pneumoniae, Haemophilus influenzae, Moraxella catarrhalis, or atypical bacteria like Chlamydia, Legionella, Mycoplasma. 6 of them, the most common organisms. All right. These 3 are going to be very common. Now, symptoms will overlap amongst each other. We really can't sit and say, okay, oh, this pneumonia is only streptococcal or this pneumonia is only Moraxella catarrhalis. It's not possible. There are certain clues which can help us, but no one can really see an X-ray and start commenting that this is only and only this pneumonia. It would not be a good thing to do that. First of all, let's confirm that it's a pneumonia. So now when we say that there is an alveoli with lot of secretions, okay, there are a lot of secretions, X-ray is showing a patch. You put your stethoscope on that area, because now you've seen the X-ray, or maybe before the X-ray you have tried to put the stethoscope, and he takes a breath. So what happens is that the secretions in the alveoli and air goes in, he takes a breath, air reaches the alveoli and the parenchyma and causes bubbling of these secretions. So in which phase of respiration? It's in the inspiratory phase of respiration. So inspiratory phase of respiration causes bubbling of these secretions, and inspiratory foreign sounds are called as rales. Rales are also the same as crepitations. Okay, crepitations and rales are the same. There is no such specific explanation or description for people who say crackles and different versions of that. But for all practical purposes, remember crepitations and rales. All right. So secretions, air goes in, bubbling of secretions. Which phase? Inspiration. Inspiratory foreign sounds are called as crepitations. So in pneumonia, what will we hear? Crepitations. All right. Now imagine, I don't know how much. See, the problem with this kind of talks, I'm not saying a problem. Shortcoming is that we can't have an eye-to-eye contact. Otherwise, I would have actually gone through each and every frame, and I would have asked a question: are you understanding? What do you feel it is? But any which ways, thanks to this app, at least we are able to meet together in some way or the other. So secretions in the alveoli, air going into the alveoli, bubbling of these secretions, and we hear the sound. It's like you have a bottle of water, there is a straw, and you blow in the straw, and we hear the gurgling sounds. So those are similar to crepitations. All right. So that's how it is that crepitations are heard due to secretions. At the same time, if at all, now everyone should understand that air is a bad conductor of sound. We talk, I was a very poor student of physics and maths, but somehow I remember this only and only this statement of physics, that air is a bad conductor of sound. So this helped me in understanding pneumonia. So imagine an alveoli which is normal and containing air, and imagine an area of consolidation which is solidified. Air is a bad conductor of sound, solid is a good conductor of sound. So when you auscultate over a normal lung and you tell the person, say 1, 2, 3, you hear 1, 2, 3. When you auscultate over this lung which is having consolidation and he says the same words 1, 2, 3, we hear it more louder. Okay, that is called as vocal resonance. So the louder sounds are called as vocal resonance, happens due to solidification of the lungs. It means that the lungs is changing and the air is becoming less and it is replaced by tissues. So I hope you are getting this about the atypical bacteria. Now, why they are called atypical bacteria? I need to spend at least a minute on this. That is Chlamydia, Mycoplasma, Legionella. When we talk of bacteria, and I explained to you that Streptococcus pneumonia is one of the commonest bacilli. It's a gram-positive cocci, Streptococcus. Okay, it's a gram-positive bacteria, whereas Haemophilus influenzae and Moraxella are gram-negative bacilli. What is gram-positive and gram-negative? I'm trying to just take you into that because I'm sure you have not brushed up your microbiology since ages. You've been busy with other patients and asthma, COPD, TB, and COVID, and so many things. But bacilli have a peptidoglycan wall. Okay, it's a wall which is made of a peptidoglycan, peptides and glycan. It's a thick wall. If the wall is thick and you put the color, which is the violet, crystal violet color, which is the shading or the stain which is there in the gram stain, then the peptidoglycan, which is thick, it retains the violet color. Okay, they are called as gram-positive organisms. In some bacilli, the peptidoglycan wall is very, very thin. So you put the stain, the violet, it doesn't pick up. Then you put the safranin stain, but it picks up. So these become gram-negative bacilli. So gram-positive bacilli are those with a thick peptidoglycan layer, and gram-negative is the one with the thin peptidoglycan layer. Okay, but they have the coloration which can differentiate between gram-positive and gram-negative. In some bacilli, there is no peptidoglycan layer, so they can't be stained. And those are the atypical bacilli. Okay, they are the atypical bacilli. So they can be stained. So they are neither gram-positive, they are not gram-negative. That's why they are called as atypical bacilli. Legionella, Mycoplasma, and Chlamydia. So that is the difference in their microbiology. But not only that, there is also a difference in their clinical presentation. So I'll give you two examples to make it a little simple. One is Dr. Sushila is seeing a patient. Okay, I'm taking her name because I can see she's written something on the chat box. But Dr. Sushila is seeing a patient, and the patient comes and says, "Madam, I'm feeling lot of discomfort. My right side chest is congested. I'm feeling a lot of cough, expectoration, difficulty in breathing, and high fever. If fever touches 102, 103 since last 2-3 days. That's the problem." And she does an X-ray which shows a localized patch, localized inhomogeneous opacity, which is a consolidation. Now she treats this patient fine. Some other patient comes to her. That patient says, "Madam, I am getting cough, but it is more or less dry. I mean, since 5-6 days I am getting a cough. Not getting much of expectoration, but my body ache, severe body ache. I can't bear the body ache. Means I have to take Crocin. Even my joints are aching, body is aching. I had some loose motions also 2-3 days back. Getting a dry cough, fever is there, headache is there." Now, madam takes X-ray, and X-ray shows different patches. A little haziness on the right upper side, little haziness on the left middle side. So both the patients have a pneumonia. Okay, both of them have pneumonia. But look at the difference. Systemic symptoms are more in atypical pneumonia. Okay, systemic symptom means loose motions, headache, body ache, joint pains, weakness, diarrheas, dry cough. Think in terms of a atypical pneumonia. Cough with yellow sputum, high grade fever, localized patch on an X-ray. think of a gram positive or a gram negative pneumonia. Of course, we are going to investigate and do so further and then come to a diagnosis. But this is just try to explain why we have to choose different antibiotics. So again, I'm perhaps offshooting from things, but Dr. Sushila is treating both of them. One patient had high fever, cough with sputum, X-ray was localized patch. So I would like to use an antibiotic which covers gram positive and the gram negative bacilli, because it could be streptococcus, it could be H. influenza, it could be Moraxella catarrhalis. So I may perhaps use a combination of amoxicillin with clavulanic acid. The second patient, dry cough, body ache, loose motions, weakness, headache. I am suspecting atypical bacteria. My drug of choice would be a macrolide like clarithromycin or azithromycin. So your line of treatment would change if you think about in terms of the microbiological aspect. Okay, so before we proceed, I'm just trying to put it all in one go. Is that patient comes with a short history, cough, fever, weakness, and breathlessness on exertion. You have understood why the patient gets cough with expectoration. You have understood about the fever, and you have understood about the VQ mismatch. If the pneumonia progresses, it's going to be leading to ARDS, which is actually a shunt. And we have also discussed about the dyspnea. Now, just next 5-10 minutes we will discuss, because I know our listening span is maybe different, but our understanding span is not more than 60 to 80 minutes. So now this X-ray, I'm sure everyone has understood, because there's an arrow pointing towards it. There's now nothing to be really, you know. Yeah, I think one question is very important. Dr. Dinesh Kumar is asking, what if the atypical viral pneumonia treatment? So we will discuss the treatment aspects, but in viruses there unfortunately no treatment. There are many viruses, millions of viruses, but we really don't have a very good treatment for each and every virus the way we have for bacteria. But maybe one of the times we will discuss the treatment aspect of each different type of pneumonia. At this moment, let's try to finish the understanding of the perspective. So this is a patch that's an inhomogeneous opacity, right upper zone. We can see it. He comes with symptoms of cough, fever, breathlessness, and so on and so forth. And we would treat it with antibiotics. So, Dr. Soumya, acyclovir for viral pneumonias, we are talking of respiratory viral pneumonias. Usually, acyclovir is a drug of choice for herpes. So, we really don't start off with an acyclovir. The commonest respiratory virus is a respiratory syncytial virus, and we really don't treat it with acyclovir. But as I said, we will discuss it sometime, because it's a very interesting topic of treatment of pneumonias as well. Now you can see this. I'll put back the earlier X-ray. Try to focus on this X-ray, the one with the arrow. Try to understand the opacity. What I mean by saying try to understand the opacity, read the X-ray, knowing the anatomy, pathology, physiology, which is happening in this person's lung parenchyma. I want each of you to imagine it, that there are neutrophils coming there, there are fibroblasts coming there, there are cytokines being released, and this area is getting inflamed. Now this gentleman comes back to you after 5 days of treatment. Let's see what happens. What do you see in this X-ray? In this X-ray, for those who have not been able to appreciate, I can say that the density has become more opaque. It has become more opaque, means more white compared to the earlier X-ray, right? It's become more white compared to earlier X-ray. So this is how the consolidation progresses. This is a lobar pneumonia. So anatomically, we can say lobar pneumonia when only one lobe is affected, multilobar pneumonia, or third is the bronchopneumonia, where there is diffuse infiltrates throughout the lungs. All right, but this is a lobar pneumonia. Now the pneumonia further progresses and it affects both the sides of the lungs bilaterally. And here the patient presents with severe hypoxia, patient is admitted, put on oxygen, not improving, and we call it ARDS. So this is the progression of a pneumonia happening because of One, either the virulence of the organism is very high, means they are very strong, they are resistant. So we are using an antibiotic, but the bacteria or the organisms are resistant. Second, host immunity is very poor. That's why I said when you investigate for blood test, please do a CBC. Why CBC? Because hemoglobin is very important aspect. You are treating a pneumonia like this, and his hemoglobin is 6. You are treating it correctly with good antibiotics, but if the oxygen carrying capacity of that patient's blood is not correct or is not good, then he is going to develop problems. So you need to interpret the hemoglobin, you need to interpret the WBC counts, even for that matter platelet counts, because any kind of severe infection suppresses the bone marrow, okay, and that may lead to thrombocytopenia. So this is one more complication, pneumonia, more dense ARDS. Now what is happening in this X-ray? Try to see the X-ray properly. Is that you can see Dr. Rucha, how much time more should we take? 15 minutes?
Yeah, so we can go up to 10 minutes, and maybe
10 minutes,
after
yeah.
that we can do a second part
Yeah, I think so,
continuation of this.
because
Yeah,
it will
it's
become
very
too
good.
much for them. So I'll just finish off these 5 X-rays, then we maybe
Yeah,
take a
yeah,
few
sure.
questions. Okay.
Yeah.
So this X-ray shows a white patch, and in the white patch you can see a blackish area. Try to localize that. There is a small black area within the white patch. Now this is how the pneumonia progresses. This progresses means there is gradually a breakdown, means there are lytic enzymes, lyse, the alveolar walls, the sac walls, the alveolar ducts are broken down by the chemicals which are released by these bacteria, and multiple alveoli coalesce together to form a large area containing air, which is actually called a cavity. So there is slowly a cavity formation. I'm just going to the next X-ray. I think this will be a better X-ray to show. You can see that there is a roundish area, which is a white line, which is round, and inside that there is a black area, which is the cavity. So this is the progression of a pneumonia. So we started from a pneumonia, continued to progress the disease. This happened because he did not go into the stage of fibrosis and resolution. It in fact became a complication of a pneumonia. So cavity formation is a complication of a pneumonia, the way ARDS is a complication of a pneumonia. All right. So this patient who has a cavitation is actually a pneumonia, either untreated, wrongly treated, resistant bacilli, host immunity poor, or some comorbidity. So one of them is leading the patient to develop a pneumonia to break down and form a cavity. Now I'm coming back to this X-ray. Now what is this X-ray showing? You can see in the right lower zone there is a opacity, and there is a obliteration of the right costophrenic angle. Okay, obliteration of the right costophrenic angle. So what's happening in this patient? So you will get such patient. That's why I'm trying to tell you this, that there's an X-ray which shows a pneumonia. This pneumonia starts progressing and it touches the periphery. Means this is the pleura. So it touches the periphery, that is a visceral pleura. The visceral pleura starts rubbing against the parietal pleura, and the fluid starts getting collected into the pleural cavity. So there is inflammation of the pleura and pleural effusion, which is called as Dr. Talat has said, Synpneumonic effusion. So there is a parapneumonic or a Synpneumonic effusion. So this is one more complication of a pneumonia. So we have gradually now entered into the realm of complications of pneumonia. So one was ARDS, second was cavitation, third is a Synpneumonic effusion. So there is a pneumonia and it has progressed. Now this is the patient who might also say the fourth symptom of respiratory disease, chest pain. So till there was pneumonia, there was no chest pain because lungs are painless. Lungs don't cause pain. But the moment the parietal pleura is touched or inflamed, patient says, लंबी सांस लेने पे ना दर्द होने लगा है. 8-10 दिन पहले नहीं था ये. Now this is meaning that his pleura is also getting entangled into the process, and he's developing pleurisy or pleuritis, and he's going to develop a synpneumonic pleural effusion. So that is the evolution or progression or complication of a pneumonia. Now, so we have talked about ARDS, Synpneumonic effusion, cavitation. Now in this cavity, you can actually see, if anyone can guess, let's see, I'll wait for at least 5 seconds. If anyone can guess what's there in this X-ray. If you may not answer, but at least mentally you can guess. I can reach your minds as well through this app. So there is a cavity, definitely. Yes. So Dr. Nihit is correct. So there is a cavitation. As per Dr. Manmohan Rathod is saying, we can see a air fluid level in the cavity. There is a horizontal air fluid level in the cavity, means that there is a lung abscess. Okay, so cavitation was there, no doubt, but now that cavity is getting filled up with pus, and that pus is settling down and forming a layer which is called as a air fluid level. So many of you have got it that yes, there is a cavity, but please remember that there is a difference in an empty cavity. Maybe you can see it here, this cavity, and then this particular cavity having a layer of fluid at the base. So that at the base of the cavity, that's the air fluid level. Now this patient, so so we have come towards the fag end of understanding the complications of pneumonia. And now we come to the sequelae of a pneumonia. Okay, sequelae. Sequelae means the permanent outcome of a pneumonia. Complications are treatable. You can treat a cavity, you can treat a lung abscess. But this is a sequelae. No, Dr. Abhishek, this is not fibrosis. There's a difference to it. So this is the sequelae. Now what happens, please remember, let's not go into X-ray. I'm going to move back the X-ray because you're going to start thinking about fibrosis. Now what happens? You try to understand the anatomy. Go back to the anatomy. The good old days of Gray's Anatomy book, which you first bought in your medical school. Go back to that. Okay. So when you are seeing a patient with a consolidation, multiple areas being affected, fibrous tissue being deposited, peribronchial fibrosis also happens. Peribronchial means along the walls there is fibrous tissue and it pulls the bronchi and distorts the bronchi. So there is distortion of the bronchi, and at places they get dilated, they get pulled, dilated, distorted, tortuous. So it becomes like a paper which is crumpled and forms multiple small cysts. Not cavities, but multiple small cysts. Now this is a sequelae of a pneumonia, and this sequelae takes almost months to years to happen. Okay, months to years. And this sequelae is called as bronchiectasis. Okay, there are multiple cysts we can see throughout the right lung. The trachea is pulled to the right side, the heart is pulled to the right side, the diaphragm is pulled, and there are multiple inhomogeneous opacity or cysts. So this is bronchiectasis. Remember, we will sometime discuss bronchiectasis, but bronchiectasis happens after a fulminant infection of the lung parenchyma. And that's the reason why you see bronchiectasis in patients with TB. Many of our patients of TB have post-tuberculous bronchiectasis. Many patients of pneumonia land up with bronchiectasis. So tractional bronchiectasis, as Dr. Bina says, cystic bronchiectasis. So all these are anatomical description of the bronchial distortion, dilatation, and destruction. But this is permanent. So this person is never going to be asymptomatic. This is a sequelae, Dr. Soumya, not a complication. Complications are treatable. Bronchiectasis is permanent. So it's an outcome, it's a sequel, it's a endpoint which cannot be reversed. Pulse oximetry, arterial blood gas, leukocyte count, blood urea electrolytes, C-reactive protein. CSF analysis is not done in everyone, of course, but we are going to think about that because bacterial meningitis is a very, very important complication of streptococcal pneumonia, especially in the pediatric age group. So we need to think of patients who are having altered sensorium, persistent fever, persistent vomiting. Don't forget to do a CSF. I mean, you may focus so much on the lungs that you're treating only a pneumonia, but the problem could be that it has progressed and it has led to bacterial meningitis also. So I think with that, I've tried to put, all the aspects right from basic to understanding and diagnosing pneumonia. One important aspect which is left yet is, of course, the management part. There are many things to discuss about it. But anyways, we will meet sometime again. So Dr. Rucha, over to you.
Thank you for
Thank you
giving
for
me an
giving me an
opportunity.
opportunity. And I'm sure I'm happy that people were actively involved in this.